we spend the most, and we have entirely undesirable population health outcomes. The big national conversation, where we're getting into this at a level that few people ever get into in public media.
Any article that says US ranks last and points to infant mortality rates, life expectancy, and leaves out Japan's obesity level, part of the OECD is 5%, and ours is 25 to 45%. Okay, welcome to the latest Scale podcast. I'm joined by John McDonough, who is professor of public policy at T.H. Chan, a Harvard School of Public Health. John, it's my honor to host you today.
Thanks. Nice to be here.
My pleasure. So let's dive in. So for anyone who's never been a student at the Harvard T.H. Chan Public Health School, which I would say of now the 20,000 audience that we currently have, is probably 99.99% of us. What does the school do? What does it feel like to be a professor there? What does it feel like to be a student there? And just give me a little bit more about your background and what you're doing specifically at the school.
Mm-hmm. So the school is a research and teaching institution. So it has about 800 faculty who are involved in every aspect of public and population health. Many of them are also physicians involved in medical care. We're divided into 9 departments that kind of demonstrate the breadth of public health. So biostatistics, epidemiology, nutrition, environmental health, social behavioral sciences, global health, U.S. Health policy. Department of Health Policy and Management is my department, and a few others. I probably forgot 1 or 2, infectious disease as well. And so we have researchers who are engaged in cutting edge research on all manner of issues and research needs in public health. Huge amount of funding from the National Institutes of Health, Centers for Disease Control and Prevention, and other federal agencies. We are of all the schools at Harvard, we are the most dependent on grant-supported research from the federal government. And so right now, we are on this day, on May 14, we are in a financial crisis because of the actions from the Trump administration aimed at Harvard to eliminate any federal money at all coming to the institution. So this is a disruptive time, the likes of which I think we've never seen in our roughly 110-year history.
It sounds that way. So first and foremost, I hope that you're able to find the funding to keep going, whether it's through the federal government or through other means. For the record, the research that you do, I'm sure, is critical to all of us. So I'm hoping that you keep going. But I want to dive into your world in a normal environment. So I'm very interested in some of the departments that you outlined and the research that takes place there. I'm going to pick on a few of them. So nutrition, we interviewed recently the former head of the FDA, Andrew von Eschenbach, and he highlighted that nutrition, despite the food, the F in FD&A, the focus historically has been on the D, the drugs. They didn't have a huge food department at the FD&A. And so he used that to explain why so much of the food intake in the US over the last 50 years has increasingly been, it turns out, unhealthy. And so my question to you is, with academic institutions like the Harvard Public Health School, why wasn't there significant research, and maybe there was, maybe it's a loaded question, to highlight to us as a populace and our political representatives how dangerous some of those food ingredients were to us, how correlated they were with incidence of diabetes and obesity, maybe, it's still a maybe, rates of autism. Where was all the research then that apparently exists in spades now?
So research as an enterprise grows over time and gathers further insights and has breakthroughs, but there have been there has been research on impacts of food and of other kinds of drugs and devices going for decades and decades. We knew back in the 1920s and 30s, for example, that smoking was bad for you. We have learned a tremendous amount about how bad and how increasingly bad it is. But that information was there. It was there in 1965 when the U.S. Surgeon General produced the landmark report on smoking and health. It didn't end smoking. It has resulted in a massive drop in smoking by adults in the United States and also in other advanced countries. So there is impact, and the research is not the decider. The research, though, has a huge impact on the people who do decide. And I just reference a more generalized, beyond, including food, but beyond food, a difference between the U.S. and, for example, the European Union. The European Union takes knowledge of something called the precautionary principle. They exercise precaution before they allow substances into the food system, into the air, into all different kinds of settings. And the United States tends to follow a whack-a-mole. When we have sound evidence that...
I was thinking of the term liberal, but I prefer the term whack-a-mole. Allow anything and then deal with the consequences.
And then deal with it afterwards. And the best example now is the substance called PFAS, PFAS, or forever chemicals, cancer-causing, extremely harmful substances that are all over our environment. They might be in your clothes that you're wearing right now. They might be in the furniture, in your drapes that I can see. It's all over, and it's very difficult. And in the EU, it's much more of a caution approach, where you have to demonstrate that something is safe before you can release it into society. And in the US, it's we go after it after we can recognize harm. And then the companies that produce this can make some small chemical changes, give it a new name, and put it back out there with the same kind of impact. So that's it. So we are part of the enterprise that tries to examine and learn. So one example...
We're the guinea pigs in the ongoing grand experiment.
A lot of it is. One of the things that came out of the School of Public Health was a recognition of the immense harm to human health from what are called trans fats that emerged in the early part of this century. And Walter Willett and our nutrition department, a world's famous expert on nutrition and science and policy, was the one who alerted the food industry to say, hey, folks, this is really harmful. This is a train that's coming right at you, and you should get this stuff out now rather than later. And so now we don't see trans fats very much at all. But that's an example. So it's not like, the academia, schools anywhere, schools of public health, come down from Mount Olympus with all the truth. We come down with some evidence-based truth, and in some cases it's wrong, and in lots of cases it's right. In other cases, it's part of a step-by-step approach of advancing human knowledge about all manner of phenomenon in society that people care about and want to know about and learn about.
So basically, if I had to regurgitate that back to you in a reductive way for our listeners, perhaps, and for me, for my benefit. Hey, Roy, give us a break. In academia, we provide good research. It's not perfect, but it's good. And by the way, we didn't even need to provide any research. All the US needed to do was take a look over across the pond and study the European way of life in greater detail. And they would have seen answers to all their questions right there over the last 50 years, but they didn't. And instead, we, for behavioral reasons, for cultural reasons, engage in more risk-taking, more leniency, more liberal policy when it comes to risk in industry, because that's just the way we are.
Yeah.
And we learn the hard way. Is that fair?
I wouldn't say the Europeans know a whole lot more than we know. I think we learn together.
In this subject,
constant exchange.
We're merging in this topic. We're merging with their more restrictive policies.
Yes.
Maybe not in everything.
Yeah, but it's not about the knowledge base. It's about policy then reacting to the knowledge base and how policy responds.
So they just like to say no without necessarily knowing why when it comes to some of these ingredients.
So they get criticized for being too restrictive and too regulatory, and then it's the reverse over here.
Agreed. I'm glad you said that. I was going to say, look, there are benefits to both, but it would be nice to be liberal when it makes sense and conservative when it makes sense. I'm not sure that either society has quite worked that out.
And you're looking to thread the needle. You're looking to walk the tightrope without falling over to either side, and you're always going to fall short. It's never going to be perfect because we keep learning.
Very well said. Very well said. Okay, so my next question, my sort of nudge, irritating question, which I recognize, but forgive me, I'm being yes, I'm being a nuisance here. So, population health versus public policy and health in general. And they seem like innocuous terms, and does it really make a difference? But what I see is two very different worlds that have been in isolation, mutually exclusive from each other for far too long, and only now emerging. And so, as I grew up in healthcare in this country, we were always last in healthcare. We ranked last, we were the worst. We had 20% uninsured rates, maybe even higher at some point. Now it's less than 10. We didn't care about our population. We overpaid for everything in every metric. Access was terrible. Equity was terrible. And the zinger that always pinned all these negative views together was life expectancy. We're supposed to be the best in the world. We win all the Olympic gold medals, but we don't live very long. Now, it seems like the story is changing. Oh, it turns out US healthcare might be great. It's a whole different set of metrics, KPIs, that are part of deciding whether the US ranks highly or lowly relative to other countries. Our population health is dreadful. But dreadful for reasons like nutrition and exercise, which in the South doesn't really get prioritized the way it does in the north of this country, looking at data. Why is this all happening now? And maybe it's the same answer. Maybe the research has been there, but I still speak to government leaders, department heads, who point to Commonwealth study as still ranking America last. Mm-hmm. Where do you fall on that topic? Population health statistics versus healthcare statistics, and what key statistics are you following to give you an indication of how we're doing as a country?
So the dichotomy normally is population health or public health versus clinical medicine, clinical care. So 15 feet away from the School of Public Health, the Harvard School of Public Health, is the Harvard Medical School, okay? And so really, in a way, what happens in Harvard Medical School is that new clinicians get trained to treat patients one at a time. And in the School of Public Health, where we do public and population health, we are dealing with populations of patients or populations of just individuals and addressing them. The Bloomberg School of Public Health in Johns Hopkins has a great tagline. I'm jealous. I wish we defined it. They said, saving lives millions at a time. That's what we try to do with population health. We try to not just deal with asthmatic children one at a time, but then develop interventions so that we reduce the growth of kids with asthma and find better ways to care for them as well over time. But so those are the essential differences. If you think about a healthcare system and what people want, by the way, different from a medical care system, I differentiate the two. A healthcare system is how healthy we have a population. Medical care is how well we treat people after they get sick or injured or something like that. And it's worthwhile focusing on the differences between those two. But what do we want from a healthcare system? We want a healthy people with longer lives, with life expectancy as long as possible, with lower infant mortality, with just some key population indicators that are as robust and positive as possible. And what we have found over the past 40 to 50 years is that on the key, most important population health measures, like life expectancy, like infant and maternal mortality and so forth, we lag way behind the other peer nations in the Organization for Economic Cooperation and Development, OECD, that Commonwealth Fund studies relates to. We fall behind, and at the same time, consistently, we spend by far the greatest amount of our national wealth on medical care services. And so there's a contradiction there. If, we had fabulous population health outcomes and we spent the most by far, we could have a great conversation about, well, is it worth the investment? But when you spend the most and you have the worst population health outcomes, then it's not illogical or hypercritical to say, something's wrong here. Something's messed up, and we really ought to try to figure it out to improve it and make it better so that everybody gets longer lives.
So you said bring it on. So here I go. I couldn't disagree. I couldn't disagree more. Couldn't disagree more. I think the maths is very wrong. As a scientist, cause and effect doesn't exist there for me, because you're presenting a vacuum argument where 1 + 1 must equal 2. But this is not the case. You're missing some inputs to that formula that could easily explain why our population health metrics have been poor on a relative basis.
But you agree that they're poor.
Oh yeah, there's no debate that they're poor. There's also no debate
and explanations. It's clear on the face of it that we spend the most and we have entirely undesirable population health outcomes. I'm not
correct, but the way that nuance of, hey, slow down on cause and effect is great hearing it from you, but it's been lost on everyone else.
Well, but so much gets lost on everyone when you get into the big national conversation, We're getting into this at a level that few people ever get into in public media.
Right. So unfortunately, any article that says US ranks last and points to infant mortality rates, life expectancy, and leaves out Japan's obesity level, part of the OECD is sub 5%, and ours is 25 to 45%, depending on who you ask and obviously which state.
Yep.
Is ignoring a critical driver of population health outcomes.
Sure. But there are so many of those key drivers. There are many of them. And we could spend a whole show on every one of them.
Right. Obesity impacts infant mortality. Obesity impacts life expectancy. Obesity impacts diabetes. Obesity impacts spend. So actually, when you think about spend, if we were to normalize our obesity levels, our spend would go down by a significant amount. I've actually done that adjustment, and I estimate 17.5% of GDP becomes 15.5% of GDP, just based on normalizing for obesity alone.
Why does that conflict with anything that I just said? I'm missing something with you. I'll push back a little bit.
So
what am I getting wrong?
It doesn't conflict with the nuanced response to what I'm saying, but I do think it conflicts with, hey, we spend more than any other country and our outcomes are worse. Therefore, we have to assume that there's something very wrong, and I'm paraphrasing, with our healthcare.
Well, do you mean our healthcare or our medical care?
And then you offer, John, our medical care.
Okay. Yeah.
Not our health. The terminology we get, what I call health, you call healthcare. Oh, I just mean health. When I talk about population health, I just mean health, not healthcare. When I talk about medical care, I use terms like healthcare or medical care interchangeably. Right. But then you said, Roy, if we had better outcomes and we were spending more, then it's worth having a debate about that. Maybe it's worth spending more to have better outcomes.
Sure.
And I'm going to push back there as well. I think we do have better outcomes in exchange for spending more, but it's lost in the aggregate. So when you look at the state by state outcomes of health, you get, and you look at county by county, and you look at counties, we have, 100 counties that have life expectancies that exceed 85 to 90 years of age. We have 50 that exceed 90 years of age. When you look at outcomes such as cancer survival rates, myocardial heart disease survival rates, heart attack rates, when you look at all kinds of important outcomes, you do find that spending more on medical school, spending more on training, spending more on infrastructure, spending more on access, all these things do actually bear fruit. It's just that the statistics of it is a little bit buried.
But if you look at our peer countries that we consider our in our class, and what you see is that they have strikingly better population health outcomes across the board for the most part, and they spend a lot less than we do, then it's certainly, you can spend as much as you want. You could make every doctor a millionaire or something like that, but it doesn't get to the basic premise that we're spending so much and getting such poor results. And what are we missing here? And part of what we're missing here is that most of the health status of the US population is not about medical care at all. It's about diet, it's about exercise, it's about air pollution, it's about all of the environmental determinants of health and other social determinants of health. That's what leads to the health outcome. I think, I teach a lot of physicians about health policy, and I have to tell them, when I go through all the bad stuff, at a certain point I have to slow down and say, listen, folks, I want you to understand, most of this is not your fault. You didn't create the obesity epidemic. You didn't create the epidemic of gun violence that we see in the United States. You didn't create the incredible amount of deadly air pollution that we have and the other toxins in our environment. So I do find it really helpful to kind of separate medical care from talks about health and population health. Clearly they overlap and intersect, but I think that confuses more than it explains. And I don't think we disagree about very much at all, at least from what I can see.
We do and we don't. So I agree with so much of what you're saying, 100%. But there are certain things that you're referencing that I would say very differently. So I actually think that the tragedy of this misdiagnosis is that we end up, at least for the past 50 years, trying to fix something that isn't that broken and ignoring something that's very broken. And we keep referencing other countries as getting it right.
Getting it better, not getting it right, getting it better.
Getting it better when in fact they've gotten it horribly wrong. And what they've gotten right is something very different. I think Europe...
What's your example? What did they get wrong?
Countries like any country in Europe. Sweden, France, Germany, Portugal, Spain, England, you name it. Every single one of them. And they vary. Germany has a slightly different approach to its healthcare, how it funds it, how it insures for it, what it invests in, number of hospitals, hospital ratios to patients. It has a slightly different approach than France, than England. I would say England is somewhat unique in the 85 to 95% government-funded, government-employed approach to healthcare through the NHS. But every single one of them suffers from gross underinvestment. I would say Germany probably the least at 12.5% of GDP. The UK, one of the highest sufferers of gross underinvestment at 9% of GDP. And every single one of them, I would say, has a very sick healthcare system. They all have great healthcare outcomes and a very healthy populace. And what's been unfortunate, tragic, is that the accolade, the rewards have gone to their healthcare system and their healthcare system approach. when in fact, when you peel the onion and you get into the actual metrics of a good healthcare system, they're nearly all dreadful. They're dreadful in terms of, forget the nostalgia towards the NHS, actual wait times. 8 million people in the UK, call it 15% of their population, are waiting to be treated, and millions are waiting to be treated 1 to 3 years. When you look at metrics like innovation, what new companies are evolving in Europe to tackle healthcare problems? When you look at technology adoption, when you look at nurse staff ratios, the UK ranks way below the US. When you look at hospital readmission rates, when you look at adoption of EMR, when you look at value-based care, which doesn't exist in Europe, when you look at coordination of care, which is an industry, doesn't really exist in Europe. When you look at patient feedback on all those things and truly define what access do you have if you're waiting 3 years to be treated, you end up with a very different conclusion. You go to Sweden, everyone's jogging, everyone's eating fish, obesity levels are near zero for a large percentage of the population. They don't really get sick. And yet you go to these countries and you ask them how they feel about doctors who are not getting paid $1 million a year. There's a shortage of them because no one is that excited to be a doctor. There's a lack of incentive. There's no incentive to be excellent, to build better. And so that's what you're supplied with over there. So I think I come back to this challenge of, I hear you. I think you recognize that we have a massive population health challenge here in the US. We can talk about whether it's getting better or not. But I think that's a very different discussion than how is our healthcare system doing. And I would certainly leave open much room for improvement. But that doesn't mean that we rank anywhere near where we've been ranked for the last 50 years.
So a lot of the things you say about Britain and elsewhere, I totally agree. Absolutely. They have some real challenges. Every system has its challenges. But think about if instead of, for the past 20 years, at levels of spending at 15 to 18% of GDP, we were, like these other countries, say between 10 and 13%. Think of what else we could have done as a society with those resources. Think of the difference it could have made in the quality of life and in investing in things that actually promote population health instead of just better medical care.
I think it's a brilliant point, and I agree with you. I think anytime we want to shine the mirror on us, a light and a mirror, and ask the question, have we got room for tremendous improvement? Is there a ton of waste in our system? Ignore Europe, ignore the rest of the world, ignore Japan. Can we do much better? I think you and I are exactly on the same page. Where the message, I think, gets very confused is when we oversimplify as a society. They're great, we're terrible, and we're terrible at everything. Fair?
Well, I mean, some people simplify, absolutely. I am drawn to the nuance, to the variations, to the differences, to getting beneath the surface of them, because that's where you find the really interesting material and where you learn the most.
But let me dive into that with you. So the nuance of how we're doing relative to the rest of the world. What are the metrics that you follow that suggest to you or signal to you, John, that we're doing great?
The United States?
Yes.
We do. I mean, if you look at the Commonwealth Fund report, it's fascinating, and just one chart.
I do.
Just one chart.
I've read it page to page.
Yeah, the money, yes. the money table where it does the overall comparisons on their 6 levels of category. What you see is that the U.S. over many years comes in consistently 1, 2, or 3 on patient care, on the quality of medical care delivered. And I think that's accurate. I think that's true. I think that we are much more aggressive in the United States in terms of trying to make medical care as advanced and as scientifically oriented as possible. And you're right, value-based care has been a major preoccupation in the US for about 15 years now, and far less so outside, though there are some countries that are much more deeply into it than Europe as a whole. So yeah, there are those differences, which is why I keep coming back to, you really need to distinguish between medical care and health, and not just lump them both together, because I think that just confuses much more than it illuminates.
I agree 100%. I've been on record as being a very big fan of value-based care. I think net it's done a lot of wonderful things for our industry, measured over the last 15 years. And I've spoken to a few of the architects and also some of the detractors. Spoke to the Senator Burr, who was in charge of the health committee that was primarily responsible for diluting big parts, large elements of value-based care. So I think on paper, it's done a lot to drive, ACA has done a lot to drive value-based care through the Innovation Lab and through the emergence of ACOs and through reimbursement policies that actually led to wide adoption, the emergence of Medicare Advantage over the last 15 years.
Medicare Advantage preceded the ACA and value-based care.
Yes.
Medicare Advantage in its roots goes back to the 1970s, so it's not a new thing.
Yes,
but it's just exploded over the past 15 years.
Yes.
Right.
Yes, along with Medicare shared savings. So look, these are difficult things to get right, but go ahead.
So I worked in the U.S. Senate for the Senate Health Committee between 2008 and 2010. So I was there during the writing and passage of the ACA. And I came out of the experience a big fan of what we call Title III, the delivery system reforms, value-based care, that whole experiment. It's all baked into Title III, and have been watching it closely and eagerly over 15 years now since the law was passed. And I think it's really hard to say at this point, with all of the money that's been invested, that the results are anything to write home to your mom about. The savings from accountable care organizations are de minimis, and depending how you count, might even be losses, and the improvements in quality are marginal. Ditto with bundled payment. Big problems with the readmission penalties and the hospital-acquired condition penalties. So, as a fan of it, I have to look at the data, at the science, at what we've learned from it, and see, well, there's a contradiction. The contradiction is that the discrete results from every element of the value-based care revolution are mediocre at best. And at the same time, here's the conundrum, here's the surprise. At that same time, overall, Medicare spending, as it was predicted to be over 10 years in the year 2010 when the ACA passed, what the CBO projected versus what happened, we've actually on Medicare on this last decade, and it's continuing, spent $4 trillion less than CBO predicted that we would spend. So there's this on the one, so there's a dual picture and it doesn't make sense. It's like looking at my screen with you and me. On one side, there are the hard results from value-based care interventions and experiments where you look at and measure, okay, what did we get from that? And there's far less there. And yet on the macro phase, there have been some tremendous advances that, except for some of the explicit price controls in Title III of the ACA, it's hard to figure out what else is going on there. And that's a conundrum. I don't have the answer to it, but we are learning a lot about it quickly.
Well, I'll give you some ideas because I've been living through some of those other trends as an operator, working with hundreds of other healthcare companies during that 15-year period. And we've seen some other revolutions. When I started 15 years ago, outpatient surgery was a lot more fringe than it is today. Now outpatient, every health system out there has an outpatient strategy, an outpatient footprint, not to mention the dedicated outpatient providers that are out there in their respective groups. So the scale of moving inpatient procedures to outpatient grows exponentially. And that's a massive cost saver for the industry.
Yeah,
We've
but
seen
who gets the results of those savings? Who sees the impact of them?
we do.
Who's
The
we?
population does.
We?
All 350 million people, every taxpayer. Because instead of paying $5,000 for an inpatient procedure, you pay $1,000 for the same procedure done outpatient, as long as you're not getting an HOPD rate for it. And the vast majority of outpatient procedures don't get HOPD rates. Some do, but the majority don't.
We are not seeing the results of those savings in terms of, say, for example, the cost of commercial health insurance or individual health insurance.
That's
I think
different.
we may see some in Medicare. We may see some in Medicare.
So you reference a massive saving in Medicare. I'll give you an even bigger saving.
Mm-hmm.
For the first time in 75 years, healthcare has not been inflationary on a relative basis. The cost of inflation has not exceeded the growth of our economy. We were at 17.5% of GDP in 2009. We're at 17.5% of GDP in 2025.
Okay.
With a blip during COVID. And so
asterisk to that.
We have flattened the curve. I'm giving you one reason. I'll give you another reason.
No, but let me respond to that. Let me respond to that before you move on, because of course, GDP on health, there's a numerator and a denominator. So we've been in a period where the economy up until this year was growing at a healthy rate. And so what that does then is it disguises the underlying increases in medical care costs.
That never worked before. So in 75 years of GDP growth on a 10-year basis, exceeding the rate of GDP growth between 2010 and 2020, it wasn't sufficient to keep up with a 10% annualized rate of inflation in healthcare, which we experienced for about 50 years, which, by the way, we're still experiencing in certain pockets of healthcare.
That's right.
We stopped doing it in drugs, but we're still doing it in hospitals. And to answer your question about insurance, it's a game. It's a fix. Insurance companies and hospitals, the five of each of them that dictate price increases to employers, still get away with it because they don't leave you with many other options when it comes to commercial insurance. So we have problems. We do have problems, but the actual spend on healthcare has been in many ways solved for over the past 15 years on a relative basis. Could we go deeper and start to cut into 17.5%? Absolutely. And between you and me, I actually think we will. I think that's what's coming next. But tremendous improvement to go from 10% of GDP to 17.5% and then to stop. Mm-hmm. Because for 75 years, all we did is go from 1% to 3% to 5% to 10%. That was a runaway train. And other changes that have happened over the last 15 years, the adoption of EMRs, which was incentivized and then through both through incentive and through punitive measures by the government during that same period of time, right? MU, I'm just forget the acronym for the policy that was enacted for every hospital system to adopt an EMR within a matter of a few years. And so the access to data on performance has coincided with ACA and the introduction of value-based care. We actually can look for value anywhere, anytime, whether you're fee-for-service or value-based care, and draw national KPIs for all providers. We see providers that oversubscribe now down to the individual, regardless of what zip code they're in.
And so why are ACOs so poorly performing by the scientific analysis? What is it not? What's not being captured?
So I feel like we've switched roles now. So I agree with you 100%, John, that the details, the actual mechanics at a grassroots level of implementation has left open tons of cracks, operational holes through which abuse has taken place, inefficiency has taken place, and a loss of savings, right? Risk-based scores that are manipulated in order to drive revenues as opposed to drive savings. This is well documented. There's been many cracks in the value-based care program. When I give it a 2 thumbs up, I give it a 2 thumbs up at the 30,000 foot level, because I see the focus on analytics and value and KPIs, hospital readmission rates, right? Preventative care, treatment plans, coordinated care inside of a network, selection of providers based on actual KPIs, managing volume of care. I see all those things as net very healthy, but I expected the actual optimization of all of that. I said before, this is very hard, to take decades, not years, like to take a long time, because this is the hardest part of care, is to understand everything and perfect treatment plans based on data. And we really only entered the age of data in healthcare in the last 15 years. I know that because I grew up in a physician family of everyone I was related to was a doctor. Every one of them used paper charts. And I used to go through the garages of these doctors, these relatives of mine, to find old patient charts that were rotting because they ran out of space to house them in their offices. That's the paradigm that we moved out of in 2008, 9, 10, 11, when ACA was introduced. I think ACA also drove coverage from minus 25%, a quarter of our population not covered, down to sub 10%. That's huge. Mm-hmm. That creates a lot more order in the system. So there's lots of things that ACA did that have resulted in steps forward, not necessarily optimization, but steps forward, notwithstanding all the abuse. I certainly accept all of that. So I think, once again, we're sort of in agreement.
As we, I used to be a big fan of Medicare Advantage. I used to be, and cheered it as it grew, because I thought there might actually be a meeting point there toward some kind of more consolidated system, which I think is one of the real difficulties we have in moving the system forward. But then what we see in Medicare Advantage today has been voracious upcoding of scores, denials of care, and all kinds of manipulation that and bounded by an incredible amount of consolidation across the healthcare system, particularly the vertically integrated behemoths of United and CVS and Humana and the others. And it gives pause. It gives pause to, yes, we've set some good things in motion, and boy, we've set a lot of questionable and difficult dynamics in motion as well at the same time.
I agree with you. All of that is true. I just still give you a round of applause for the experimentation and the positivity that will come from it. Within most organizations, not all, there are well-intentioned operators that are trying to make things work. That still leaves room for a lot of subjective ideas on whether you're doing good or not for society. So look, these are hard things to solve for. Every one of these steps requires tremendous analysis of not just where we are today, but where we're heading, right? What will this ultimately lead to 5 years from now? So none of this is easy, but I do recognize the good intentions, and our industry, I believe, gets better measured by KPIs all the time. I'm going to ask you one more question because I want to be sensitive to your time. I know you need to go somewhere on the hour. State level performance in outcomes. So we've been having a conversation about the US in aggregate. I mentioned differences between the North and the South. I don't think this topic gets enough airtime. As an academic at probably the most important institution for analysis that we have, how do you think about the Marylands of this world? Our good friend Mina is now Secretary of Health there. She's just starting, versus the Massachusetts of this world, versus the New Yorks, the Floridas, the Texas of this world, versus California. These all feel like very unique approaches to healthcare policy, from same rate for everyone to at risk to value-based care to full-on open market. Let's do fee for service. There's wide disparity in the policies that these state legislators take. Do you study that variance in outcome, and do you have examples of what you love and examples of what you hate?
Yeah, so I in the fall I teach a course, United States Health Policy, and in the spring I teach a course called State Health Policy, because the truth is you can't understand the U.S. system in a helpful way without looking at, exploring, and understanding the enormous variation in states. I mean, if we took out the states of the old Confederacy, sorry to say that, but if we took them out of the picture and just look at the results for the other 40 states or so, U.S. measures on health would skyrocket. So and it doesn't come and it, you know, there's for what I've learned, what I appreciate, and what I think most people is there are education, income, and insurance coverage are the three predominant factors that will determine your life expectancy. The more money you make, the higher your education, and if you have health insurance, you are in a different class. And in the southeastern part of the United States, it is a developing nation status down there in terms of health status, particularly for the poor, disadvantaged populations, which tend to be non-white. And these are the states that have refused to expand Medicaid as permitted by the Affordable Care Act. But you have to look at it in terms of the cost control. You have Maryland, which has hard-edged hospital rate setting, very regulatory, very controlling. And you have Massachusetts, which is more, let's have a stakeholder approach where we bring people together. We put out absolute, relevant, and compelling data through the Mass Health Policy Commission. But I think what it is, and it's constant, and this has been true forever, is that what you see at the state level is the experimentation. Are the trying out different directions, new ideas, old ideas recomposed into something different. And so it's terribly important, terribly interesting all the time. And normally, as happened with Massachusetts and the ACA, state experimentation, when it's done really well and succeeds and takes off, then catapults federal policy making forward.
Well, I would love to, if I had my drudges, I'd love to see all 350 million of us much better informed on different state experimentation within healthcare. I think we follow variance in state policy on many other topics like crime, like immigration, like education. We follow these differences between California and Texas, but we rarely have the conversation about healthcare policy. And I think it's so rich and interesting because these experiments, they all, just like value-based care, just like ACA, the experiments are valuable in themselves. And there's a lot of knowledge there. So, John, I hope that you lead that charge, and I hope that you use platforms like ours to help drive that awareness. You do great work on behalf of our entire population. It's people like you. It's schools like yours. God bless you. And we're here to help you any which way we can. Thank you for your time today.
Okay. Thank you. Pleasure to be with you. Good luck.
Got it, John.
Okay. Great.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.